So in this video, we're going to look at Chapter 21, which is talking about a control of respiratory function. This will be a nice review of the respiratory system, going back to anatomy and physiology. So in terms of functions of your respiratory system, we know it's involved with gas exchange, and this occurs at the microscopic components of your lung tissue, which would include things like your alveoli and alveolar ducts and respiratory bronchi. And because of the fact that those structures are so thin, we actually get some gas exchange there, like oxygen can move into blood down its diffusion gradient, and CO2 can move out of blood and into air of your lungs down its diffusion gradient. We also know that your lungs act as a really good barrier against infection because we have lots of mucus in there that can trap microorganisms. We have cilia that help to move that mucus out of the respiratory tract. And then we also have surfactant, which acts as an antimicrobial agent, as well as macrophages or dust cells that help to engulf debris and microorganisms that you may have inhaled. Now, it actually does regulate some of the vasoconstriction substances like bradykinin, angiotensin II, and heparin. Like angiotensin II is activated by angiotensin converting enzyme found in the blood vessels of your lungs. So if you look at just an overview of the respiratory system, we know that it's divided into upper and lower respiratory tracts. The upper respiratory tract is everything that's respiratory related above the larynx. So we start talking about like the nostrils, the nasal cavity, the nasopharynx, the oropharynx and laryngopharynx, all that, as well as the paranasal sinuses, all of that's part of the upper respiratory tract. And if it's the larynx down, all of that's part of the lower respiratory tract. So your larynx is your voice box, and that's going to communicate or connect with the trachea, which then splits into two main bronchi. The right main bronchus serves the entire right lung, and the left main bronchus serves the entire left lung. Now, all of this part of the respiratory system, like the upper respiratory tract and even the lower respiratory tract leading all the way up to the alveoli, is part of the conducting zone. So the conducting zone's purpose is really just to transport air into and out of the respiratory passages. And then we have the respiratory zone, which is actually going to include your alveoli and your respiratory bronchioles, as well as alveolar ducts. And it's these microscopic structures here that this is where gas exchange occurs or respiration occurs. And it's because these structures are so thin that diffusion can occur across their membranes rapidly. Now we know that each lung is actually supported to the inner thoracic wall by a little bit of pleura, and the pleura serves two purposes. Yes, it does support the lung to the inner thoracic wall and to your respiratory diaphragm, but the pleura also functions as a lubricant because as your lungs are expanding and contracting, they need to have low friction, and so it's the pleura that surround your lungs that provide that low friction and a decrease in resistance. So if you look here, what we find then is a visceral layer of pleura, which is right on the lung itself, and then a parietal layer of pleura, which is actually going to line the inner thoracic wall, and they're separated by a pleural space, which is filled with serous fluid. Now that serous fluid functions as a lubricant, but it also helps to provide some of the surface tension that allows for your lungs to have a tendency to want to adhere to the inner thoracic wall. So what's cool then about your pleura is they actually help to keep your lungs open or inflated. If there were damage to the pleura, such that it were ripped and that air filled this or blood or other fluids filled this, the lung would actually start to shrivel down to a smaller size because it's so elastic. Its natural tendency would be to shrivel under its own elasticity. So the conducting zone we talked about was part of the upper and lower respiratory tract, but really it's including all the structures where air moves, but gas exchange doesn't occur. So air moves into and out of the lungs, and the function of the conducting zone is to warm and humidify that air, as well as trap inhaled particles within mucus or hair along the airways. And most of your respiratory tract is the conducting zone. And it's not until you get to the respiratory bronchioles, alveolar ducts, and alveoli where respiration occurs, or gas exchange. So the respiratory zone is the respiratory bronchioles and alveoli, and a gas is exchanged here with your blood. And the reason why a gas exchange can occur at this level, like it's microscopic, is that these structures, respiratory bronchioles and alveoli, have very thin walls. And those walls are so thin that gases can move across them rapidly. And so that oxygen is going to move down its diffusion gradient into the blood, and then carbon dioxide is going to move down its diffusion gradient into the air of your lungs, where then it's able to be exhaled. So if you look at the structure of the airway of the walls of your respiratory system, it turns out that your upper respiratory tract is lined with a pseudostratified ciliated columnar epithelium, and even parts of the lower respiratory tract as well. Now, this pseudostratified ciliated columnar epithelium basically has a lot of goblet cells, and the function of these goblet cells is to secrete mucus. Now, this mucus bathes the whole apical surface of this epithelium, and then we have cilia that are projecting up into that mucus layer, and their role then is to wave around and move that dirty mucus up and out of your airways where it's either spit or swallowed. But the larger airways are also supported by cartilage, and this hyaline cartilage actually maintains the patency or openness of your larger airways by giving it more structure. Now, in the bronchioles, what we find is that you're going to switch from the pseudostratified ciliated columnar epithelium to more of just like a simple cuboidal, where there's might be still some cilia here, until we get all the way down to like the alveoli, where we get a simple squamous epithelium. And we have type 1 and type 2 alveolar cells. Type 1 cells are the thinnest, and actually this is where gases can be exchanged. In fact, if you zoom in here, this is considered the respiratory membrane, where you have the type 1 alveolar cell, basement membrane, and then the endothelium of a capillary. That's the respiratory membrane. Very, very thin, like 1/2000th of a millimeter thick. Now, we also have type 2 cells here, and if you look closely, you can see little secretory granules, because the function of these type 2 cells is to secrete surfactant, which maintains the patency or openness of your alveoli by reducing the surface tension of water. So it makes the water and mucus of your alveoli less sticky, so that way the walls of the alveoli don't collapse and stick together. So if we look at the structure of these alveoli, alveolus translates to grape. So if you look at these, it's kind of like grape-like clusters here, very thinly walled. In fact, you can see capillaries wrapping around each alveolus. This is significant because this is the point at which a significant amount of gas exchange can occur. Now, if you look at some of the larger airways, they're going to be wrapped in smooth muscle. And the function of this smooth muscle is to help regulate the diameter of the airway, so you can regulate airflow. Air is going to flow from high to low pressure. And then once that air enters the alveoli, then it can participate in gas exchange with the bloodstream. So gases in the blood, like CO2, can diffuse into the air-filled spaces of your alveoli down their concentration or diffusion gradient. And then like oxygen in the air can diffuse into blood. And then pulmonary veins can carry that oxygenated blood back towards the left side of the heart. Now, what keeps these alveoli open is not just the fact that they have a membrane here, but we actually have surfactant that lines the inner surfaces of these alveoli. And the surfactant is essentially a molecule, it's a glycoprotein, that breaks this surface tension of water. And so it actually interferes with the cohesiveness of the hydrogen bonds of water, and therefore prevents the alveoli from sticking together. Like you can imagine then if the water in here was cohesive enough, then the walls of these alveoli could collapse in on itself and become sticky. But the surfactant reduces that stickiness or surface tension to keep these open or patent. So this question here says, which serous membrane lines the thoracic cavity? And we're talking about the inner thoracic wall. So technically this would be the parietal pleura, right? We said the parietal pleura is on the outside of the organ, but this would line the inner thoracic wall or cavity there. And so this would actually support the lung to the inner thoracic wall. This is important to keep your lungs inflated and open. If this parietal pleura is damaged, your lungs could collapse, and we'll talk about that with disorders of atelectasis. Now, respiratory muscles, their function is to help, with ventilation, and ventilation is airflow. Now, like blood rather, air moves from high to low pressure. So what we need then are muscles to help generate pressure differentials in our respiratory tract. That way we can move air either into or out of the respiratory tract. So we have things like our respiratory diaphragm, which separates the thoracic and abdominal cavities, and the accessory muscles of inhalation or inspiration would be things like your external intercostals, scalenes, and sternocleidomastoid. So we're saying that muscles that you find between your ribs, as well as some of the muscles of your neck, are going to help with inhalation. We also have muscles of forced exhalation, which would be like your internal intercostals and abdominal muscles. So the way these work then is that for inhalation, like the diaphragm and these accessory muscles, their purpose is to expand the thoracic cage or increase thoracic volume. Because if you increase thoracic volume, pressure inside the thoracic cavity decreases such that air in the atmosphere is going to be in higher pressure than air inside your thoracic cavity, so that air wants to flow in from high to low pressure. This is achieved by increasing the volume of your thoracic cage. This is because the volume is going to be inversely proportional to pressure. So if you increase volume, you decrease pressure. And the same goes with exhalation. If you decrease volume, you're going to increase pressure. So these muscles here are going to decrease the volume of your thoracic cage, thereby increasing the pressure of the air within that thoracic cage. So it's going to force that air out of your body to a lower pressure, which would be in the atmosphere. So true or false? During inhalation, the diaphragm contracts and flattens. Well, we talked about how the diaphragm is going to be involved with, increasing thoracic volume. So this would be true, because by increasing thoracic volume, by flattening and sort of contracting here, you're going to increase the volume of the thoracic cage, which is going to be helpful for inhalation, which is what we're talking about here. Now, during exhalation, the diaphragm just relaxes back to a resting shape, and that's going to, by itself, just decrease thoracic volume, which increases pressure, which is going to allow that air to be forced out. So one of the things that acts to help us determine the ease of ventilation or airflow is this idea of lung compliance. So compliance refers to the stretchability of your lungs. So how easily these lungs can be inflated. Now, this depends on three major factors here. It depends on the fiber content of the stroma of your lungs, like the elastin and collagen fibers. If these are present in normal amounts, then your lungs will have a certain amount of compliance or stretchability, as well as elasticity. As well as the water content, too. Like if your lungs have enough water in them, and not too much or too little, they're going to have good ease of stretchability. This is also going to depend on the amount of water you find in the pleural cavity, as well as surface tension. Remember, we said that surfactant inside your alveoli reduces the surface tension of those alveoli. If you had high surface tension in the alveoli, they would stick together, and therefore your lungs would be less compliant, because every time you went to inhale, you'd have to fight the internal stickiness of your lung tissue. So fortunately, we reduce surface tension with surfactant. So this scenario here says a man's lungs were damaged during a fire, and he developed severe respiratory distress. Doctor said smoke inhalation caused inflammation of his alveoli and destroyed some of his surfactant here. So in this example, if he lacked surfactant, what's going to happen to his lung compliance? Well, we know that surfactant reduces the stickiness of your alveoli, and if your alveoli are less sticky, then they're going to be more compliant. So in his example, his lungs would be less compliant because he made less surfactant. So you can imagine then that the alveoli could be stuck together on the inside. So why was he given positive pressure ventilation? Well, positive pressure ventilation would actually force air into his lungs, and this is going to help him achieve proper ventilation and airflow. Otherwise, if he had to rely on his own respiratory muscles, they might not be strong enough to pop those sticky alveoli open. So positive pressure ventilation can force air with a lot of oxygen into the lung tissue. So in terms of lungs, volumes, and capacities, these are important to consider when you start thinking about pathophysiology and helping to determine someone's lung health. So tidal volume just refers to the volume of air that someone can ventilate during normal, quiet breathing. This happens to be around 500 milliliters or so. Inspiratory reserve volume would just be the volume of air that you can inhale at the peak of tidal volume. So how much air can you inhale totally? And then expiratory reserve volume is how much air can you exhale at the trough of tidal volume. So how much air can you, totally exhale as well. And then residual volume refers to the volume of air that's just trapped in your lung tissue. So if you have a lot of residual volume, then we're saying that there's a lot of trapped air, which would be bad in terms of respiration, because if you can't get all that old air out of the lungs, then it's going to mix with other air, which is going to decrease the concentration of O2 and keep your CO2 levels higher inside your lungs. So residual volume exists like in normal healthy lungs, but you're going to have higher residual volume if someone's lungs are damaged. Now, lung capacities include things like vital capacity. Now, vital capacity refers to the total amount of air someone's able to achieve in terms of like expiratory reserve volume, tidal volume and inspiratory reserve volume. Now, functional residual capacity refers to essentially expiratory reserve volume and your residual volume together, and then total lung capacity is just all of it together. Residual volume, expiratory reserve volume, tidal volume, and inspiratory reserve volume. All of that together will be total lung capacity. How much air can you fit in your lungs at its maximal level? Now, in terms of determining lung function, we can look at different factors here, like maximum voluntary ventilation. This just refers to, how much air can someone move through volition. Just sort of, if you ask them to breathe heavily, how much air can they ventilate? Now, forced vital capacity would refer to if you ask someone to take the deepest breath in, followed by their deepest breath out, and you measure the amount of airflow, that's forced vital capacity. And then forced expiratory reserve volume would just be the amount of air that they can expire, if you ask them to just expire from normal tidal volume. And then we have forced expiratory volume in 1 second and minute volume. So forced expiratory volume in 1 second is just the amount of air that someone can force out in 1 second if you ask them to. Like if you just said, okay, now force out air, and they go, and it's been 1 second, you can look at the slope of that curve and how much air they're able to expire in 1 second, and that will actually give you a lot of information about their lung health just in 1 second of data. And then minute volume just refers to how much air can they ventilate in a whole total minute. So these are some different factors you can use to determine someone's lung health. So this question here says, which measure of lung function indicates the total amount of air that the lungs can hold? Is it tidal volume, functional residual capacity, vital capacity, or total lung capacity? Well, we talked earlier about how it's total lung capacity. Now, it's not vital capacity, because vital capacity is just your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. But total lung capacity also includes your residual volume. So that's going to be basically all the all the air that your lungs can hold. And in a normal, healthy individual, on average, it ends up being about 6 liters, which is actually quite a bit. So in terms of gas exchange, we talked about how oxygen moves from alveolar air into blood, and carbon dioxide moves from blood into alveolar air. And what determines the direction of this movement is ultimately just diffusion. So the reason why gases move from the air of your alveoli into blood is that by the time blood gets to the lungs, it's going to be low in O2 with respect to the alveolar air. So due to diffusion, oxygen is going to move from air into blood, from high to lower concentration. And this is how oxygenation occurs, which is ultimately a passive process, which is pretty slow. This is why we need a lot of surface area for proper oxygenation to occur. And the same goes for carbon dioxide. By the time that blood gets to the lungs, it's going to be higher in CO2 because carbon dioxide is a waste product of your metabolism, and that CO2 is then going to move from high concentration of blood into lower concentration, which is the air of your alveoli, and then it's ventilated out. So this ventilation perfusion idea here tells us about how you want to send blood to the alveoli that are the best ventilated, right? If alveoli get good airflow, then you would expect them that should also get good airflow, and vice versa. So in this scenario, we said that an inhaled peanut blocks a left primary bronchus, right? So the left primary bronchus is pretty large, and so if this peanut blocks that, we're saying that you're going to limit airflow to the entire left lung, right? So how will ventilation of the two lungs change? Well, the left lung will actually get poor ventilation. The right lung will get, normal ventilation. And how will the composition of air in the two lungs differ? Well, if the left lung is having poor ventilation, then we're saying that's going to be low in O2 because you're not replenishing O2 in there. It's going to be higher in CO2 because of the fact that you're not getting rid of that CO2. Versus the right lung, you'll have more O2 and less CO2 because it's getting properly ventilated. So which lung should receive more blood then? Well, it would make sense to send more blood flow to the right lung if it's getting better ventilation. And so the body can alter perfusion to the lungs by vasoconstricting, right? Like you could vasoconstrict one of the pulmonary arteries such that you get more blood flow to one lung and not the other. In this example, you want to send more blood flow to the right lung. So you'd want to vasoconstrict the left pulmonary artery. That way there's less blood flow to that lung. And you could vasodilate the right pulmonary artery to increase blood flow to the right lung. So in terms of ventilation perfusion mismatch here, this is going to occur under conditions where you either have like damaged alveoli or damaged blood vessels. And this is actually going to be where blood goes to parts of the lung that don't have oxygen to give it. Now, this is not a good thing here because we're saying that blood might not go to the parts of the lungs that have enough oxygen and vice versa. So if you look at the mismatch, some examples could be like, okay, if we have an obstruction of an alveolar duct and you get poor airflow of the alveolus, if you're still sending blood to the alveolus, then it's not going to get oxygenated before it goes back towards the heart. Or let's say if you had a blocked blood vessel, such that you had good airflow but poor blood flow, then you're just wasting this airflow to the alveolus that really just isn't going to pick up any oxygen anyways. Now, normally you should have airflow matched with blood flow, such that you get enough air flowing to alveolus, gas exchange occurs so you can pick up oxygen in the blood and deliver CO2 into the air, and then that oxygenated blood with low CO2 can then travel back towards the heart. Now, if you look at this in terms of comparing the effects of all three together, you'd see then that if this did happen, then for the blood that's going back towards your heart, then that's going to essentially be mixed with hypoxic blood. So it's going to have lower oxygen content. So true or false here, ventilation perfusion mismatch results in hypoxia. Absolutely, right? Because if you get poor airflow or poor blood flow, in either condition, you're not going to get oxygenated blood, and such that you're going to lead to hypoxia, which is low oxygen in the blood. So in terms of blood gases, we can measure this in terms of dissolved oxygen, and we call this PaO2 or PO2. A normal value of PO2 would be like 80 millimeters of mercury. Now you can think about this is actually a pressure, but you can think about this as also being a concentration. So 80 millimeters of mercury would be the normal amount of oxygen pressure you find in someone's blood. Now, when oxygen is bound to hemoglobin, it forms oxyhemoglobin, and under normal circumstances, you're going to find then that hemoglobin will have 95 to 97% saturation, which means that of this 80 millimeters of mercury of oxygen, 95 to 97% of that is found on hemoglobin. Now, hemoglobin holds 4 oxygen molecules, and what's really cool then is that for the hemoglobin that's in your blood, it's got 4 subgroups. You got 2 alpha, 2 beta, and you have about 250 million molecules of hemoglobin per red blood cell, so that every red blood cell can hold approximately 1 billion oxygen molecules. So how could a person have a hemoglobin saturation of 95%? Well, this comes about because not all oxygen is bound to hemoglobin. Some of it's actually loose, like you're going to find it not bound to hemoglobin, but rather dissolved within the cytoplasm or dissolved within plasma. And that's important because we need hemoglobin to transport that oxygen and then help deliver that oxygen to tissues that need it the most. And you wouldn't want that oxygen to always be just sort of free and moving around, because you would find then that the tissues that got the blood flow first would get the most oxygen, but that might not make sense for your body. For instance, you might send blood through a lot of different muscles before it gets to the muscle that needs it the most. So we'll talk about this oxygen hemoglobin dissociation curve that helps explain how hemoglobin can deliver oxygen to tissues that require more oxygen. So oxygen capacity just refers to the amount of oxygen your blood can hold. And so the normal capacity of oxygen in blood is actually quite a bit. We're saying that you can probably fit about 20 milliliters of oxygen per 100 mils of blood under normal circumstances. And with anemia, it could be as low as like 10 or even less. So you're saying that you actually might carry half as much oxygen in blood if you have anemia. So if you look at these different curves here, this is showing the oxygen hemoglobin dissociation curve. And let's just focus on curve A first. And really what this is showing us is hemoglobin saturation from 0 to 100%, and then partial pressure of oxygen in solution. We said that under normal circumstances, you're going to be around 80 millimeters of mercury of oxygen, right? It's actually between 80 and 100. You're going to vary around this kind of location here. And so then if we look at the amount of hemoglobin that's saturated under these conditions, what we find then is that if you have a lot more oxygen in blood, hemoglobin will get pretty much almost 100% saturated, right? Now, if you start decreasing the amount of oxygen you find in blood, then your hemoglobin saturation goes down. And what this means then is that we're saying that as a fraction of this total amount of oxygen you find in blood, more of that oxygen is going to be loose and less of it's going to be bound to hemoglobin because hemoglobin is less saturated here. So let's say if you have 80 millimeters of mercury of oxygen and you go up here and you see, okay, well, we find that at 80 millimeters of mercury, we say that oxygen saturation is around 90% or so, right? So we're saying that of that 80 millimeters of mercury, the other 10% of that oxygen is actually not on hemoglobin, and rather it's going to be loose in the solution or available in solution, which means that tissues can actually use it, right? But let's look at 100 millimeters of mercury. At 100 millimeters of mercury, we're saying that hemoglobin is about 97% saturated or so pretty close to 100, which means that of that 100 millimeters of mercury of oxygen, only 3 is actually going to be loose in solution. So, you might wonder, well, what's the difference here? Well, it actually makes sense with respect to the tissues, right? Because if your tissues are using a lot of oxygen, you'll find that there's less oxygen in the tissue. And if there's less oxygen in the tissue, you're going to want that oxygen then to unbind from hemoglobin and therefore be free in solution. That way the tissues can use it. So if you follow this curve down, we find that the general tendency then is that at lower and lower concentrations of oxygen, hemoglobin becomes less and less saturated. This is significant because now we have then is that your hemoglobin can release that oxygen under periods of time where your tissues need it the most. And what's really cool too is that this curve can change under different conditions. Like you can have left shifts and right shifts in hemoglobin. So a left shift of this oxygen hemoglobin dissociation curve is basically showing us that at the same partial pressure, let's go back to 80. So if you look at 80, at the same partial pressure concentration of oxygen, if you shift to the left, we find that hemoglobin's even more saturated at the same concentration. So what this means then is that hemoglobin is binding to oxygen more strongly. So a left shift in this curve would mean that hemoglobin saturation is stronger and its affinity for oxygen increases, which means that hemoglobin is going to hold on to that oxygen much more strongly. And then a right shift would be the opposite. If you go back to 80, we find that, at the same partial pressure, hemoglobin's even less saturated than the other curves. And so a right shift would actually decrease the affinity of oxygen and hemoglobin. And you might wonder, well, why would you ever want left shifts or right shifts? Well, a right shift is actually going to cause your hemoglobin to bind with oxygen less strongly and therefore deliver that oxygen in the tissues. So what would cause that? Well, a decrease in pH, like acidic tissues, or an increase in temperature, or an increase in CO2, because all of those are characteristics of tissues that are very metabolically active. They're going to be warmer, they're going to be more acidic, and they're going to have more carbon dioxide. It turns out all 3 of those factors cause a right shift, so that if tissues are more metabolically active and giving off those sort of features like heat, and more acidity, it's going to cause your hemoglobin to desaturate or actually bind to oxygen less strongly. And the opposite is true of a left shift. If your tissues are cooler or more basic or have low CO2, that's going to cause your hemoglobin to hold on to that oxygen more strongly, which is what a left shift here is. And so what's really neat then is that hemoglobin then can alter its affinity for oxygen based on whether or not a tissue needs more or less oxygen. That's just ultimately what this curve is telling us here. So in terms of anemia, we talked about this in the previous slide. We said that in normal hemoglobin, let's say at 100 millimeters of mercury, you have almost 20 milliliters of oxygen per 100 mils of blood, if things are normal. In anemia, it could be as low as 10. So if you're anemic, like let's say if you have low red blood cell count or low hemoglobin inside your blood cells, we're saying that your total oxygen carrying capacity could be as low as half as much as what it would be in normal situations, which means that you can't transport as much oxygen, so your tissues they're just going to be hypoxic. You're not going to be able to oxygenate your tissues as well in conditions like anemia. So with oxygen release, we say that if blood's release is half of its oxygen in the tissues, how much oxygen will the normal tissues receive? Well, essentially this would depend on what the oxygen hemoglobin dissociation curve tells us, right? So if blood released half of its oxygen to the tissue, this could be something like 20 millimeters of mercury of oxygen, or like 20% of hemoglobin saturation. It really just depends on what the curve is. And this next question says, how much would an anemic person's tissues receive? Well, obviously not as much as a normal individual, because if you have 20 milliliters of oxygen per 100 mils of blood, and you release half of that in the tissues, then you're saying that the person might get as much as 10 mils of oxygen into those tissues. And in an anemic person, if they're already at 10 milliliters of blood per 100 mils of, 10 milliliters of oxygen per 100 mils of blood, and they release half of their oxygen content, that's only 5. So they're only going to release 5 milliliters of oxygen in their tissues if they're anemic. So it's significantly less. So most body tissues have a PO2 of 40 to 60, like in the periphery. And this makes sense with respect to being lower because the tissue is going to use that oxygen. So we're saying then here, says how much oxygen does the normal blood release at a PO2 of 40 millimeters of mercury? Or how about anemic blood? Well, if we go back to our curves here, let's check out 40 millimeters of mercury. We see that under normal circumstances, we see then, at 40 millimeters of mercury, your hemoglobin's only going to be about 70% saturated, which means then that you could, the remaining concentration of oxygen, then that 30% is going to be in the blood. And if we look over here, then we see then, we have about 15 milliliters of oxygen in 100 mils per blood. So then that could be, several milliliters of oxygen in the tissue at that point. And that would be good because then you can supply oxygen to the tissues that need it the most because they have lower oxygen content. In an anemia, it's going to be much lower because you can see their carrying capacity is even lower. So in terms of, like carbon dioxide, we know that CO2 can be transmitted by hemoglobin, but most CO2 is actually going to be transported in a form called carbonic acid. So although some CO2, it's very, very small percent, can bind to hemoglobin, forming carbaminohemoglobin, ultimately we find that most CO2 is converted to carbonic acid. This is actually done through an enzymatic reaction using carbonic anhydrase. So water and CO2 can form carbonic acid, which then can dissociate into bicarbonate ion and hydrogen ion, so that when you exhale and remove CO2 from your blood, you're also going to remove that carbonic acid, which is going to raise your blood pH or make it less acidic. So it's kind of an interesting phenomenon here. In fact, bicarbonate ion also serves as a nice little pH buffer. So although you're making acid in your blood when CO2 levels rise, you're also turning that into a buffer which helps to stabilize blood pH. So true or false here, the relationship between pCO2 and pH is direct. Is it true then that if your CO2 levels rise, your pH would rise? And that's absolutely false, right? It's indirect. So as pCO2 levels rise, the amount of carbonic acid in the blood increases, then dissociates into hydrogen ion, which makes your pH more acidic, which actually decreases it. So they're actually indirectly related. And this is what we talked about back with, with metabolic and respiratory acidosis. We said that if you had metabolic acidosis, your respiratory system can try to compensate by breathing more heavily and getting rid of that carbonic acid, but it's going to have an indirect effect on pH because you might not be directly affecting other acids in the blood as well. So in terms of respiratory control centers, we find those in the medulla oblongata and the pons. So your brainstem is really like the respiratory center of your body. Now it does receive some higher inputs, like so from conscious brain centers, you can consciously cause yourself to breathe more heavily or breathe more slowly. However, auto-regulation of your respiratory rhythm is under the control of pontine and medullary nuclei. This is important to consider because as long as someone has their brainstem functioning properly, then they're going to be able to control normal respiratory rhythm. So the dotted lines here show afferent input, right? Like input going to the brainstem. And you can see that that input comes from places like your nasal cavity, your pharynx, your carotid bodies, part of your lower respiratory tract, your lungs itself. And all of this is going to provide your brainstem with input about respiratory rhythm. So you might wonder, well, what kind of information does the nose, pharynx, respiratory tract, and lung provide? Well, that's going to give your brainstem information about irritation or stretch. Like if your lungs stretch too much, we actually have a hearing-Brewer reflex that inhibits your respiratory rate. That way you don't overstretch your lungs. And then if your nasal cavity, your pharynx, your respiratory passages, or your lungs are irritated, that's also going to inhibit respiratory rhythm. And you might wonder, well, what information comes from your bloodstream? Well, pH, right? We said that your aorta and carotid bodies have, pH sensors, and these pH receptors can provide the brainstem with information about blood pH, so that your brainstem can make the appropriate adjustments to respiratory rhythm. That way, you can adjust your pH accordingly. So, for instance, if your blood pH was too low, like too acidic, you can increase the diaphragm contraction rhythm or rate. And that's going to help you to expel more CO2 to get your blood pH back up to a normal level, right? Now, all these solid lines here represent motor output to different muscles. So you can have motor output to the respiratory diaphragm, there's motor output to the intercostal muscles, and there's motor output even to the smooth muscle of your airways as well. That way you can actually regulate airflow towards the lungs. So in terms of measuring pH of your blood, it's done through central and peripheral chemoreceptors. The central chemoreceptors measure PCO2 and pH in CSF. And so what happens then is that you actually have receptors in your cerebrospinal fluid of your central nervous system. That's what they're called, central chemoreceptors. So if PCO2 levels rise or your pH changes, then these receptors then can provide information to your brainstem about that concentration change. Now, the peripheral chemoreceptors sense or receive information about changes in O2. So the peripheral chemoreceptors would be located like in the carotid bodies or your aorta, so that if PO2 levels are too low, then that can cause an increase in ventilation. That way you get more oxygen into your bloodstream. Now, the scenario here says you're caring for a client with COPD, or chronic obstructive pulmonary disease. Type A COPD is emphysema. And this individual has chronically high PCO2, right? Their PCO2 levels are high because they have difficulty with ventilation. And this individual is being given a low flow oxygen and complains all the time that he needs more air, right? So you turn up his oxygen because he feels like he needs more air, right? Now when you go back, you check on him later and he's unconscious and not breathing. You might wonder, well, what happened here? Well, we know that, in conditions like COPD, if their O2 levels get too high, like their blood oxygen levels get too high, they can actually undergo apnea. So if you increase oxygen delivery to the tissues through the respiratory system, and you stop relying on PCO2 levels, what's really weird then is that individuals can have normal O2, but then their compensatory response then is to stop breathing. And we call that apnea. And the purpose of this then is to, prevent your O2 levels from getting too high and prevent your CO2 levels from getting also too low. And so this breathing response, like not breathing, would come from the fact that his O2 levels were, high, and the compensatory response then here was to stop breathing. We don't need to breathe anymore because our O2 levels are normal. But the problem though with this is that this individual might have high O2 and high CO2 levels as a result. So if their CO2 levels are high in their blood, that means their blood's going to be acidic. And if they stop breathing, their blood's going to become even more acidic. And you're going to see respiratory acidosis, which can lead to a whole host of problems. So this would not be a desirable effect.